Welcome to the Deep Dive. Today we are embarking on a really comprehensive exploration into a critical area of the body, the upper limb.
That's right.
We're going deep into orthopedics, looking at common conditions affecting everything from the shoulder down through the elbow and into the incredibly intricate machinery of the hand and wrist.
Yeah, and our guide for this journey is specific excerpts from a core text used by surgical professionals. Our mission isn't just to skim the surface.
No.
It's really to extract all the essential information presented within these sources, the detailed anatomy, the underlying pathology, how conditions are diagnosed, the management strategies. Everything. So you can build a really deep understanding of this complex region, truly grasping the concepts like the experts do.
Think of this as your way to really master this information. We're navigating the full spectrum, from the fascinating mechanics of the shoulder's range of motion to the specific problems that can crop up in just a single fingertip.
Exactly. We'll pull out key insights, maybe some surprising facts, and just enough detail to help you really understand why things happen and what can actually be done about them.
Okay, let's dive in. Our journey begins right at the top with the shoulder girdle. Now, you might think of the shoulder as just one joint.
Right. Most people do.
But as our source material highlights, it's actually a coordinated system. It involves three main bones. The clavicle, that's your collarbone, the scapula, or shoulder blade, and the humerus, the upper arm bone. That connects to the scapula at the main ball and socket joint, right? The glenohumeral joint.
That's the one. And it's interesting, the only direct bony link between the entire arm and your body's central skeleton is the sternoclavicular joint.
Where the collarbone meets the breastbone.
Precisely, where the clavicle meets the sternum.
Yeah.
Now, muscles like the deltoid and that really crucial rotator cuff group, that's the subscapularis, supraspinatus, infraspinatus, and teres minor, they're obviously key for controlling that main joint.
Right.
But the source points out there are actually 26 muscles that cross the glenohumeral joint.
26.
26 total, all working to control the arm's position relative to the body.
Wow. That really underscores the complexity. And the scapula, that shoulder blade on your back, it isn't just sitting there, is it?
Not at all.
Yeah.
It's absolutely essential for full shoulder movement. It glides and rotates on the chest wall. So when you lift your arm all the way up 180 degrees,
Yeah.
that motion isn't just happening at the ball and socket.
Right. So where does it come from?
Well, about 50 degrees of that total, 180 actually comes from the scapula rotating.
50 degrees just from the shoulder blade.
Yeah. And the clavicle elevates too. That adds another, say, 30 to 60 degrees. The rest of the motion, the remainder, happens at the glenohumeral joint itself.
Okay.
And critically, as you lift the arm up overhead, both the humerus and the clavicle have to rotate. The humerus rotates externally.
Thirds outwards.
Exactly. And that's a really neat bit of mechanics because it helps shift a bony bump on the humerus, the greater tuberosity.
Where the cuff tendons attach.
Some of them, yes. It shifts it out from under the acromion, that bony arch of the shoulder blade, and a ligament called the coracoacromial ligament.
So it stops things getting pinched.
Precisely.
Yeah.
It prevents pinching and allows for that full, smooth elevation.
So that impressive range isn't just the main joint. It's this perfectly timed dance between all these parts.
It really is.
But sometimes this complex system doesn't form quite right from birth. The source mentions some congenital abnormalities.
Yes, it does. The most common one is called Sprengel's shoulder.
Sprengels, okay.
It happens when the scapula doesn't fully descend from where it starts higher up in the embryo. Otto Gerhard Karl Sprengel described this way back.
What does it look like?
You see a shoulder blade that sits too high on the back. It's often smaller than normal and kind of rotated. Sometimes it's even connected to the neck bones, the cervical spine.
Connected? How?
By a band of fibrous tissue, or sometimes even a bony bar. The source calls it an omovertebral body.
That sounds like it would really restrict movement.
Oh, it certainly can. And there can be other related congenital issues too. Rib abnormalities or problems in the neck and upper back like scoliosis.
Curvature of the spine.
Right. Or Klippel-Feil syndrome. Maurice Klippel and Andre Feil described that. It's where some of the neck vertebrae are fused together from birth.
Interesting.
Another one mentioned is pseudoarthrosis of the clavicle.
Pseudoarthrosis. Like a false joint.
Exactly. A false joint where the clavicle should be one continuous bone. It can sometimes be mistaken for a birth fracture that just didn't heal properly.
Didn't they fix that?
Well, the source actually warns that attempts to fix it surgically, with plates or bone grafts, usually fail.
Good to know. Okay, so stepping away from conditions you're born with, many shoulder problems are acquired later on. When someone comes in with shoulder pain, the story they tell, the history that seems absolutely foundational.
It's truly vital. I mean, there might be one obvious event that brought them in, but you need the full context.
Like what?
You need to know, did the pain start suddenly or gradually? How long has it been going on? Their age is important, their job. What do they do with their shoulder all day?
Right, the demands.
Exactly. And is it their dominant arm? And crucially, you must ask about neck problems.
Because the pain can come from the neck.
Yeah.
Referred pain.
Very often. Pain in the shoulder and arm can definitely be referred from pinched nerves in the neck. But the source gives a helpful clue here.
Oh, yeah.
If the patient can point really precisely to one specific spot in the shoulder where the pain is worst, it's less likely to be referred pain from the neck, more likely originating in the shoulder itself.
Okay, so the history guides you.
Yeah.
How do you then use the physical examination? What are you looking for?
Well, the goal often is to either reproduce the pain or find specific weakness. For inflammation or pinching impingement, you put the arm in positions that recreate that painful situation.
Like the Hawkins test you mentioned earlier.
Exactly.
Yeah.
That's a classic example described by Richard J. Hawkins. You flex the arm forward, then rotate the hand inwards across the body.
And that does what?
It's designed to deliberately squeeze the rotator cuff tendons right under that bony arch, the acromion, and the coracoacromial ligament. If that causes pain, it strongly suggests impingement is the issue.
Okay. And if you suspect a tear?
Then you're specifically testing muscle strength. You're looking for weakness that doesn't just go away if the pain is managed. And for instability, like if the shoulder feels loose or like it might pop out,
Yeah.
you use apprehension tests. You carefully move the shoulder into positions where the patient feels that sensation that, uh-oh, it's going to slip out feeling.
Right. Investigations seem tricky, though, given how much of the shoulder is soft tissue, like tendons and muscles.
Well, plain x-rays definitely have limitations for seeing tendons and muscles clearly.
But they're still useful.
Oh, incredibly valuable. They show the bones perfectly, obviously. And they can show certain indirect signs, like an x-ray might show that the space under the acromion looks narrower than usual.
Which suggests?
It can be a sign of a significant full-thickness rotator cuff tear, because the humeral head rides up a bit without the cuff holding it down. X-rays also show bone spurs under the acromion or arthritis in the AC joint, that joint between the clavicle and scapula.
And you mentioned the shape of the acromion itself can be important.
Yes, the source describes 3 common shapes: flat, curved, and hooked.
Hooked.
Yeah, like a little bony hook pointing downwards. And people who have impingement pain and rotator cuff tears are much more likely to have that hooked type of acromion.
Does the hook cause the problem?
Well, that hook often forms because of calcium deposits building up in that coracoacromial ligament. And there's actually a bit of a debate mentioned in the source.
About
Does the spur cause the cuff problems by physically pinching it? Or is the spur actually a result of the ongoing wear and tear, the degeneration and irritation of the tendon itself? Kind of a chicken and egg situation.
interesting question. So x-rays show the bones. What about getting a good look at the soft tissues like the rotator cuff?
For the rotator cuff's integrity, its health, ultrasound, and MRI are excellent.
What's the difference?
Ultrasound is quicker, cheaper, and you can do it while moving the arm, which is sometimes helpful. MRI gives more detailed pictures, really beautiful anatomical detail.
And if you suspect damage to the labrum, that cartilage ring,
Then an MR arthrogram is often the best bet. That's where they inject contrast dye directly into the shoulder joint before the MRI. It outlines structures like the labrum much more clearly, especially showing tears.
okay. And those local anesthetic injections you mentioned, they can help diagnose too.
Absolutely. They can be a crucial diagnostic tool, really helping to pinpoint where the pain is coming from. Charles Sumner Neert II, a real pioneer in modern shoulder surgery,
Wait,
he described Neer's sign or test for subacromial impingement. The idea is if a patient has pain when they lift their arm, especially through that painful arc,
yeah.
and then you inject local anesthetic into the subacromial bursa, that little fluid-filled sac under the acromion, and the pain completely disappears.
Then the pain must be coming from that space.
Exactly. It strongly suggests the pain originates right there in that subacromial space.
That makes perfect sense. If numbing a spot stops the pain, that's probably the culprit. Let's use that understanding to explore specific shoulder conditions, starting with that very common problem: rotator cuff degeneration and impingement.
Okay. So at its core, this condition involves the rotator cuff tendons and muscles working in a pretty tight space, a sort of tunnel.
Between the bones.
Right, between the humeral head below and the acromion and that coracoacromial ligament above. And the source points out a really key factor here. The rotator cuff, especially in an area sometimes called the critical zone, it has a relatively poor blood supply, which means it doesn't heal or repair itself very well when it gets damaged or worn.
And it tends to get weaker with age.
Yes. Degenerative changes are very common as we get older. This leads to tendinosis, which is basically wear and tear, frayed tendons, and eventually that can progress to partial or even full thickness tears. There might even be a genetic component to it.
Okay.
And what often happens is maybe a minor injury or just repetitive overhead activity starts this kind of vicious cycle. Yeah. The initial irritation or wear makes the rotator cuff muscles not work quite right, so the tendon doesn't glide smoothly under the acromion anymore.
Right.
This poor gliding causes inflammation and swelling, both in the subacromial bursa and the tendon itself. That's the impingement phase.
Oh, the pinching.
Exactly. And then the pain and inflammation from that impingement further inhibit the muscles.
Making the gliding even worse.
Precisely. Leading to poorer gliding, more inflammation, more pain, and the cycle just keeps going.
The cycle of pain and dysfunction. And this relates to that painful arc you mentioned.
Exactly. The classic painful arc describes pain specifically when you actively lift your arm out to the side, usually somewhere between about 60 and 120 degrees of abduction.
Why that range?
It's thought that's the zone where the inflamed part of the tendon or the swollen bursa is getting pinched the most as it passes under the acromion and any spur that might be there.
Okay.
And the source contrasts this with pain from the AC joint, the acromioclavicular joint, which typically happens much higher up, sort of in the last 20 or 30 degrees of elevation.
That's a useful distinction.
Yeah. And another helpful point is that someone with impingement might really struggle to lift their arm actively through that painful arc because of the pain.
Right.
But if you, the examiner, gently help them lift it passively, they might be able to move past that painful zone and continue the movement relatively pain-free.
Okay. So how do you try to break that cycle and treat impingement?
Well, the first goals are always pain relief and restoring normal shoulder mechanics. Injecting a corticosteroid.
Steroid shot.
Right, a steroid shot into that subacromial bursa. The source shows diagrams of this. It can be very powerful at reducing the inflammation and pain.
By some relief.
Hopefully it gives enough relief to allow the rotator cuff to start functioning better and break that cycle. Then physiotherapy is absolutely crucial.
To get things moving properly again.
Exactly. To restore normal movement patterns and strengthen the muscles around the shoulder girdle.
And if that doesn't work, if the pain persists?
If symptoms are severe and they've been going on for a while, say 3 to 6 months, despite good conservative treatment like injections and physio, then surgery might be considered.
What does that surgery involve?
The most common procedure is called a subacromial decompression. It's often done arthroscopically, keyhole surgery.
What do they do?
They basically create more space for the rotator cuff. They remove that bony spur from the underside of the acromion, maybe trim a little bit off the front edge of the acromion bone itself, and release that tight coracoacromial ligament.
Literally making more room.
Exactly. Now, the source notes something important here. While this surgery is generally pretty good at relieving the symptoms of impingement, there isn't strong evidence that it actually improves the long-term prognosis for the shoulder, or that it prevents rotator cuff tears from developing later on.
That's a key insight.
Yeah.
Symptom relief versus actually preventing future problems.
Yes, and it's highlighted right there in the source material. And this brings us back to that important distinction between impingement or tendinosis and a true rotator cuff tear.
Right.
So, just to recap from the source. Tendinosis or bursitis causes weakness primarily because of pain. If you numb the pain with an injection, the strength might actually come back.
Okay.
But a significant rotator cuff tear causes weakness that persists even after the pain is relieved with an injection because the muscle tendon unit is physically broken.
That makes sense. So that leads us directly into talking about rotator cuff tears themselves. How do they progress from just simple degeneration or wear and tear?
Well, because of that relatively poor blood supply we talked about, and just the effects of age and cumulative wear, that degenerative process can eventually lead to actual tears forming within the tendons.
Where do they usually start?
They typically start in the supraspinatus tendon, usually towards the front and side, the anterolateral aspect. From there, they can progress backwards to involve the infraspinatus and sometimes even the tears minor tendons.
And once they tear, they don't just heal up on their own.
Generally, no, not spontaneously. As the tear gets larger, the torn end of the tendon can actually pull back. It retracts.
Like a rubber band snapping.
Kind of like that, yeah. It pulls away from its attachment point on the humerus bone, leaving a bare area.
Is there a difference in how tears happen in younger people versus older people?
Absolutely. In a younger person with generally healthy tendons, a rotator cuff tear usually requires pretty significant trauma, like a hard fall directly onto the arm or shoulder.
Mm-hmm.
But in older adults, tears are much, much more common. They can happen from relatively minor things, like a simple slip or fall, or sometimes they seem to occur almost spontaneously, just as part of that ongoing degenerative process.
Right.
And it's really crucial to understand, the source points this out very clearly, that asymptomatic tears are incredibly common in older adults.
Meaning tears that don't cause any pain.
Exactly. Tears that show up on an MRI or ultrasound, but the person has no symptoms whatsoever. Estimates range from maybe 4 to 20% of people in their 40s and 50s having a tear they don't know about.
Wow.
And up to maybe 30% of people in their 70s might have a full thickness tear without any pain or significant functional problems.
So finding a tear on an MRI in an older person doesn't automatically mean that tear is the cause of their shoulder pain.
Precisely. You have to correlate the imaging findings with the clinical picture, the patient's symptoms, and the examination finding.
How do you do that?
Well, if a patient has significant pain and a tear on the scan, and you do that diagnostic injection we talked about, if the local anesthetic relieves the pain but the weakness persists.
The weakness doesn't go away.
Right. That strong, lingering weakness points towards the tear being symptomatic, being the source of the problem.
What else do you look for on examination with a symptomatic tear?
You'll often find pain, obviously, but also noticeable weakness. Difficulty actively lifting the arm out to the side. That's active abduction. Sometimes you can even see a wasting of the shoulder muscles if it's been going on a while.
Muscles shrinking.
Yeah. And often a characteristic sort of hunching or hiking up of the shoulder when they try to raise their arm because other muscles are trying to compensate. Specific tests, like the empty cant test for the supraspinatus, can help isolate which muscle might be torn.
What imaging is best for actually seeing the tears?
Ultrasound and MRI are the go-to investigations. They're both excellent at detecting tears. They also give really important information about the quality of the remaining tendon and muscle tissue.
Why is that important?
It's crucial if you're thinking about surgical repair. Is the tendon tissue healthy enough to hold stitches? Has the muscle become fatty and wick? That affects the chances of a successful repair.
How are tears classified?
It's commonly by size. Small tears are usually less than 1 centimeter, intermediate are maybe 2 to 4 centimeters, and large tears are greater than 5 centimeters.
And the treatment for a rotator cuff tear. Is it always surgery?
Definitely not always surgery. It's very patient dependent. It varies hugely based on the patient's age, their activity level, what demands they put on their shoulder, and how severe their symptoms are.
Okay.
And you have to remember, rehabilitation after rotator cuff surgery is a substantial commitment. It often takes a good 3 to 6 months, sometimes longer, of dedicated physiotherapy.
Right.
So surgery might not be the right choice for everyone, especially maybe for older, less active individuals, or people who absolutely need their shoulder for weight bearing, like using crutches.
What are the surgical options if it is needed?
Options include arthroscopic or sometimes mini open repair of the torn tendon, often combined with that subacromial decompression we discussed earlier. Outcomes are generally better in younger, more active patients, especially if the tear is relatively recent or traumatic.
What if the tear is massive or it's been there for a very long time? Are they harder to fix?
They can be very challenging, yes. If the tear is huge and chronic, the tendon might have retracted way too far back, making it impossible to pull it back to where it belongs. Or the muscle tissue itself might have undergone severe wasting and lost its ability to contract properly. That's called fatty atrophy or fatty infiltration.
So simple repair isn't possible then?
It might not be. In those difficult cases, the source discusses more complex options, things like tendon transfers, where you reroute another healthy muscle and tendon to try and take over the function of the torn one.
Right.
Or using patch grafts to bridge the gap.
Wow.
Or even using specialized types of joint replacements, like the reverse geometry total shoulder replacement.
The reverse one again.
Yeah.
Where the ball and socket are swapped.
Exactly. It puts the ball part on the scapula and the socket part on the humerus. This changes the mechanics so that the big deltoid muscle on the outside of the shoulder can lift the arm effectively, even if the rotator cuff is completely gone or irreparable.
That reverse replacement sounds like a really clever solution for a tough problem. Let's pivot now to another condition. one that's often characterized by severe stiffness. Frozen shoulder, medically known as adhesive capsulitis,
Right. This one is a bit of a mystery condition, actually. It's often called idiopathic.
meaning we don't really know why it starts.
Pretty much. The hallmarks are progressive stiffness and often significant pain. It's most common in women, typically in their 50s. And there are some known associations with other conditions like diabetes, heart disease, and thyroid problems. It can also sometimes follow a period of immobilization, maybe after an injury or surgery, or even just pain from another shoulder problem.
What does it actually feel like for someone experiencing this? How does it start?
It often starts with quite severe pain, sometimes seemingly out of the blue, or maybe after a very minor, insignificant injury. Then stiffness starts to set in and gradually gets worse.
What's the key finding on examination?
The absolute key feature is a global restriction of movement. That means the shoulder is stiff and limited in all directions.
All directions, not just one movement.
Correct. It's stiff when the patient tries to move it themselves, that's active range of motion, and when someone else tries to move it for them, passive range of motion. And it's usually limited by pain initially, then later by actual tightness. The source calls out a classic, highly suggestive sign:
Which is?
significant loss of external rotation when the arm is held tucked into the side. That's often dramatically reduced.
How do you distinguish it from other things that cause stiffness, like arthritis?
Well, a key point is that plain x-rays in frozen shoulder are typically completely normal.
Ah, okay. So that helps rule out significant osteoarthritis or maybe a fracture?
Exactly. The source mentions you should consider things like infection or maybe a massive rotator cuff tear. But the global stiffness across all movements without obvious signs of infection like redness or warmth points away from infection. And while a big cuff tear can limit active movement,
Right.
it usually doesn't cause such a dramatic loss of passive motion in all directions, which is really characteristic of that thickened, tight joint capsule you get in frozen shoulder.
How long does it typically last? Does it get better on its own?
The natural course of frozen shoulder is usually quite long, often 1 to 2 years.
Okay.
It can sometimes linger even longer, especially in people with diabetes.
1 to 2 years.
Yeah, it's a long haul. It typically evolves through distinct phases. First, a painful phase where the stiffness is increasing. Then a frozen phase where the stiffness is maximal, but the pain might actually start to lessen a bit. And finally, a thawing phase where motion gradually, slowly starts to return.
So it does tend to resolve eventually.
The good news is that yes, even if left completely untreated, most people eventually regain pretty good functional motion. But it takes time.
So treatment is mostly aimed at managing the symptoms during that long process, getting through it.
Exactly. In the early, painful phase, pain relief is the absolute priority. Steroid injections can be very helpful here,
Into the joint or under the acromion.
either into the subacromial space or directly into the glenohumeral joint itself. They can be particularly effective during that initial stiffening phase. The source also mentions a specific technique called a distension injection or hydrodilatation.
What's that?
That involves injecting a relatively large volume of fluid, usually saline and local anesthetic, directly into the glenohumeral joint under a bit of pressure. The idea is to physically stretch out the tight capsule and maybe break up some adhesions.
Does it work?
It can sometimes help facilitate movement, yeah. And throughout the process, patients are strongly encouraged to keep moving the shoulder gently within their pain limits, usually with guidance from a physiotherapist.
What if the stiffness is just really prolonged and disabling? Are there surgical options?
Yes, if things aren't improving after a long time. Operative options include manipulation of the shoulder under anesthesia.
Where they physically move the arm to break the stiffness?
Exactly. They carefully but forcibly move the shoulder through its range of motion to break the adhesions. Another option is arthroscopic release of the tight joint capsule.
Keyhole surgery again?
Right. Using a camera and small instruments to surgically cut the thickened, tight parts of the capsule. Both manipulation and release can help improve pain and speed up the recovery of motion in those stubborn cases.
Okay. Another distinct shoulder problem involves calcium deposits, right? Calcific tendinitis.
Yes, calcific tendinitis. This is where calcium salts, basically calcium crystals, build up within the rotator cuff tendons. Most often it's in the supraspinatus tendon.
Why does that happen?
It's generally considered a degenerative process, part of wear and tear, and it might be linked to underlying partial tendon tears. Sometimes it's just found incidentally on an x-ray and maybe causes some chronic low-level ache.
But it can flare up badly.
Oh, yes. It can present acutely with sudden, extremely severe pain. This often happens in slightly younger individuals than typical rotator cuff tears.
What does that acute attack feel like?
It's often described as a very rapid onset of excruciating pain, sometimes waking the person from sleep. The shoulder is usually very tender, and motion is markedly restricted because of the pain.
Is it like frozen shoulder then?
Not quite. A key difference is that, unlike frozen shoulder, external rotation is usually still possible, although it will likely be very painful. And the diagnosis is usually clear on imaging.
You can see the calcium.
Absolutely. The calcium deposits are typically clearly visible on plain x-rays and also on ultrasound.
How do you treat it? Especially that acute pain.
Subacranial corticosteroid injections are often the first step, trying to calm down that intense inflammation and pain. Other procedures that can be helpful include needling the deposit.
Sticking a needle in it.
Yeah, repeatedly puncturing it with a needle, sometimes trying to aspirate the chalky calcium material or flushing it out with saline, that's called barbotage.
Does it go away on its own?
Often, yes. The condition is frequently self-limiting over time, and the body may eventually just resorb the calcium deposits. But for cases that are really persistent and resistant to other treatments, surgery can be considered.
What kind of surgery?
Usually arthroscopic or sometimes open removal of the calcium deposit itself, often combined with the subacromial decompression to make sure there's enough space.
Okay. Moving on from tendons and calcium, arthritis can affect the main shoulder joint itself, the glenohumeral joint.
Definitely. Both rheumatoid arthritis and osteoarthritis are relevant here.
Let's start with rheumatoid arthritis, RA. That's systemic, right?
Yes. RA is a systemic inflammatory disease that attacks joints throughout the body, and the glenohumeral joint is frequently involved.
What does RA do to the shoulder joint?
You see characteristic changes. The bones around the joint tend to become weak and porous. That's osteoporosis. The cartilage gets destroyed by the inflammation. The joint lining, the synovium, becomes thickened and inflamed, forming this destructive tissue called pannus.
Pannus.
Yeah, pannus. It actively erodes the bone and cartilage. And very importantly, in the shoulder, the rotator cuff tendons are often weakened, thinned, and eventually torn by the disease process.
How is rheumatoid arthritis of the shoulder treated?
Well, the primary treatment is managing the underlying systemic disease, often with powerful medications like biological therapies these days. Locally, intra-articular steroid injections can provide temporary pain relief. Historically, they used to do arthroscopic synovectomy, removing that inflamed joint lining, but the source notes that the newer systemic drugs have largely superseded that.
What about surgery like joint replacement?
Shoulder replacement surgery in RA patients can often be more challenging than in osteoarthritis.
Why is that?
Because the bone quality is often poor due to the osteoporosis, and those crucial stabilizing structures, especially the rotator cuff, are frequently damaged or completely torn.
So a standard replacement might not work.
An anatomical total shoulder replacement, the standard kind, really requires a functional rotator cuff to work properly and be stable. So if the cuff is deficient, which it often is in RA, but the bone stock is still reasonably okay,
Right.
then a reverse geometry shoulder replacement is often a very good option.
That reverse one again?
Yeah. The primary goal of any shoulder replacement in RA, just like in OA, is pain relief. Getting more motion is great, it's a bonus, but pain relief is key. And the reverse replacement often provides better motion than an anatomical one when the cuff is gone.
Okay, what about the more common type, osteoarthritis of the shoulder? Wear and tear.
Right, glenohumeral OA. This can be primary, meaning it just develops over time without a clear preceding cause.
Does this happen?
Yeah. Or it can be secondary, meaning it develops as a consequence of something else, like a previous major injury, a fracture into the joint, maybe a past infection, or sometimes it's the end-stage result of long-standing massive rotator cuff disease. That's called cuff tear arthropathy.
What are the typical symptoms of shoulder OA?
Pain is usually the main complaint. It's
Yeah.
typically activity-related, gets worse over time. Stiffness is also common, especially trying to reach overhead or behind the back. You might hear or feel grinding, crepitus.
And on examination?
You'll find reduced range of motion, often limited by pain or by the bones physically bumping into each other because of bone spurs, osteophytes.
How is shoulder OA treated?
First line is always non-surgical. Pain relief medication, activity modification, physiotherapy to maintain motion and strength as much as possible. Steroid injections can give temporary relief.
And if that's not enough?
If the pain and functional limitation are significantly impacting quality of life, then surgery is considered. One option sometimes used, especially in younger, more active patients trying to delay a full replacement, is arthroscopic debridement.
Just cleaning out the joint.
Yeah, basically cleaning out loose cartilage fragments, trimming frayed edges, maybe removing some bone spurs. But the source notes the results can be unpredictable.
So the main surgical option is joint replacement. Arthroplasty.
Yes, joint arthroplasty is a common and generally very effective option for significant pain relief in shoulder OA. There are different types. A total shoulder replacement, or TSA, replaces both sides of the joint, the ball, humeral head, and the socket, glenoid.
Okay.
A hemiarthroplasty just replaces the ball side, the humeral head. Generally, the TSA provides better and more predictable pain relief than the hemiarthroplasty.
Does the rotator cuff matter here too?
Absolutely. Just like in a terrare, a standard anatomical TSA requires an intact and functional rotator cuff for stability and optimal function. If the cuff is severely damaged or absent, like in cuff tear arthropathy,
Then what?
then the options are usually either a hemiarthroplasty or, more commonly these days because it gives better function, that reverse polarity TSA.
It keeps coming up.
It's become a really important tool for these difficult situations. Again, the main goal of shoulder arthroplasty for OA is pain relief. Regaining full motion, especially reaching high overhead, is less predictable than getting good pain relief.
What about fusing the shoulder joint? Arthrodesis. Is that ever done for OA?
It's much less common for OA compared to, say, post-traumatic situations or RA complications. It's typically considered only in very specific cases for OA, maybe a younger patient who does extremely heavy manual labor and needs a completely stable, pain-free shoulder above all else. Or maybe someone with a history of severe joint infection where putting in an artificial joint is too risky. Or perhaps certain neurological problems like a brachial plexus injury affecting the shoulder muscles but sparing the hand and elbow.
What's needed for a fusion to work?
The patient must have good, strong control of their scapula. They need to be able to shrug powerfully because all the motion they'll have after the fusion comes from the scapula moving on the chest wall.
So they still have some movement?
Yes, the source notes that patients actually retain a surprisingly fair amount of functional motion after a shoulder fusion, but it's entirely from scapulothoracic movement. The glenohumeral joint itself is solid.
Okay. Shifting just slightly outwards now to the joint right at the top, where the collarbone meets the shoulder blade, the acromioclavicular joint, or ACJ. That can be a source of problems too.
Oh, very common. ACJ arthritis is actually extremely common to see on x-rays, often just as an incidental finding when looking for something else.
So it doesn't always cause pain.
Often doesn't, no. But when it is symptomatic, causing pain, it most frequently affects males, often between 20 and 50 years old. It can be related to previous trauma, like a fall onto the point of the shoulder. Sometimes, a bone spur forming on the underside of the ACJ can grow downwards and start impinging on the rotator cuff tendons passing underneath it.
What symptoms point specifically to the ACJ being the problem?
The pain is usually related to activities, especially things like reaching across the body, like putting on a seatbelt or lifting overhead. You might see a little prominence or bump at the very end of the clavicle, and the joint line itself is usually tender if you press on it.
Any specific tests?
Pain is often reproduced by flexing the arm forward and then bringing it across the chest toward the opposite shoulder, the cross-body adduction test. And remember the painful arc.
Yes, 60 to 100 for impingement.
Right. The painful arc for ACJ problems is typically much higher up, usually in the last 20 to 30 degrees of overhead elevation as you reach the very top. That's a useful distinguishing feature. And of course, if there's an associated bone spur causing impingement, you might also see signs related to the rotator cuff.
How do you treat ACJ problems?
An injection of corticosteroid directly into the ACJ itself can often provide good pain relief, and it's also diagnostic. If the pain goes away, you know you've found the source.
And if injections don't provide lasting relief?
If symptoms persist, surgery involves removing a small piece, usually about 0.5 centimeter to 1 centimeter from the very end of the clavicle, the distal end.
Taking out the arthritic joint surface?
Exactly. It's called an excision arthroplasty or Mumford procedure. It can be done arthroscopically or through a small open incision and is generally very effective at relieving the pain from ACJ arthritis. If the main problem is actually impingement from a spur underneath the ACJ, then the surgery would focus on arthroscopically removing that inferior osteophyte, combined with a subacromial decompression to address the rotator cuff impingement.
Okay, now the long head of the biceps tendon runs through the shoulder area as well, and that can rupture, can it? causes quite a noticeable change in appearance sometimes.
Yes, that typically occurs in older adults. It's often due to degeneration of the tendon itself, sometimes associated with wear and tear within the bicipital groove where it runs on the humerus bone. And it's frequently linked with underlying rotator cuff tears. They often go hand in hand.
What's interesting is that the rupture itself isn't always super painful.
That's right. Many patients don't experience severe pain from the rupture, but rather they notice a sudden event, maybe a pop or a snap, or a feeling of giving way near the shoulder. And then they see the change in their arm's appearance.
The bulge.
Yeah. If they had biceps tendonitis before the rupture, the pain might actually feel better afterwards. Bruising often appears down the upper arm, and then, when they flex their elbow, the biceps muscle belly bunches up lower down in the upper arm than usual.
Creating that characteristic bulge.
Exactly, sometimes called a Popeye deformity or sign, and that bulge is permanent. Initially, there might be some slight weakness in the elbow flexion or forearm rotation, and maybe some cramping pains, but overall function often recovers surprisingly well.
So is surgery usually needed to fix it? Reattach the tendon?
For most older adults, the answer is usually no. The main treatment is reassurance.
Just letting it heal.
Well, the tendon itself doesn't reattach, but the pain and bruising will resolve, and the strength usually improves significantly over several months as other muscles compensate. Surgery, which is called a biceps tenodesis, where they reattach the tendon end somewhere else, usually lower down on the humerus.
Yeah.
That's generally not considered necessary for functional improvement in this age group. It might be considered purely for cosmetic reasons if the patient is really significantly bothered by the appearance of the bulge.
Okay. Now let's delve into problems of shoulder instability. This often means the joint dislocating, right? Popping out.
Yes. The source helpfully categorizes shoulder instability into three broad types, which is a useful framework.
What are they?
First, there's traumatic instability. This is caused by a significant injury, a definite event that causes the shoulder to pop out, usually in one specific direction, most often forwards anteriorly. This type is typically involuntary, and it often responds well to surgical repair.
Okay, number one is traumatic.
Second is atraumatic instability. This type doesn't necessarily follow a specific major injury. It's often multidirectional, meaning the shoulder feels loose or slips out in multiple directions, forwards, backwards, downwards. It can be painful and involuntary, and it can respond to surgery, but sometimes requires different techniques, and the focus is often heavily on physiotherapy first.
Right. Traumatic, atraumatic. What's the third?
Third is habitual instability. This is distinct because it's often voluntary. The person can consciously, intentionally pop their shoulder out or partially out.
Like a party trick.
Sometimes, yeah. This type is typically painless and is strongly associated with generalized ligamentous laxity, being double jointed. And crucially, the source emphasizes that surgery is usually not recommended, it's often contraindicated, for this group because it tends not to work well long term.
Okay, that's a really helpful classification. Let's focus on the most common type first. Recurrent traumatic anterior instability.
Right. This is the most frequent scenario, especially when we talk about first-time dislocations in younger patients, say under 25 years old. The shoulder almost always dislocates forwards and usually a bit downwards, anteroinferiorly.
And once it's happened once,
it tends to happen again more easily. The first dislocation usually requires a noticeable force, but subsequent dislocations often occur with less and less force, sometimes with simple movements like reaching backwards or throwing. Patients might experience full dislocations where the joint stays out and needs to be put back in reduced, or episodes of subluxation where it just partially slips out and then pops back in on its own.
after the joint is put back in place, how do you check for that underlying instability?
Once the shoulder is reduced and the initial pain settles, the range of motion might actually return to near normal. A key clinical sign you look for then is a positive apprehension test.
The O feeling.
Exactly. You carefully move the patient's arm into a position of vulnerability, typically abduction out to the side, and external rotation. As you gently push it further into external rotation, someone with instability will get a sudden sense of impending doom, a strong feeling or fear that the shoulder is about to dislocate again, and they'll resist the movement.
What kind of damage happens inside the shoulder with these dislocations? What shows up on imaging?
CT scans, or even better, MR arthroscopy, are very helpful here. They often reveal specific damage caused by the dislocation. Very commonly, you see damage to the labrum.
That cartilage rim around the socket.
Yes. A classic injury is a Bankhart's lesion, named after Arthur Sidney Blundell Bankhart. This is where the labrum gets torn away from the front and bottom edge of the glenoid socket rim.
So the bumper is torn off.
Essentially, yes. Sometimes that tear actually includes a piece of the bone from the glenoid rim itself that's called a bony Bankhart lesion. You also frequently see damage on the other side on the humeral head.
What's that?
As the humeral head dislocates forward, the back of it often impacts against the front edge of the glenoid socket. This can cause an indentation fracture on the back of the humeral head, known as a Hill-Sachs lesion, named after Harold Arthur Hill and Maurice David Sachs.
So damage on both the socket side and the ball side. When is surgery usually considered for this recurrent traumatic instability?
Surgery is generally indicated if the patient experiences repeated dislocations, or if they have persistent symptoms of instability like frequent subluxations, or that constant apprehension feeling that significantly interfere with their activities, sport, work, or just general quality of life.
And what does this surgery involve?
For this common anterior instability, the standard surgery is aimed at fixing that damage. Usually, it involves repairing the torn labrum, the Bankhart lesion, reattaching it back to the glenoid rim, and often they'll also tighten up the stretched out joint capsule at the front of the shoulder.
Can this be done arthroscopically?
Yes, it's very commonly done arthroscopically now, but open surgery is also an option. The source notes that this type of repair is generally quite successful, preventing further dislocations in about 90 to 95% of cases.
That's a pretty good success rate.
It is. However, if there are significant bone defects like a large bony Bankhart lesion on the glenoid, or a very large Hill-Sachs lesion on the humerus just repairing the soft tissues might not be enough. In those cases, bone grafting procedures might be needed to rebuild the bone and restore stability.
What about instability in other directions, like posterior?
Posterior instability is less common, but also usually treated surgically if it's recurrent and symptomatic, by repairing the posterior labrum and tightening the back of the capsule.
You mentioned earlier that posterior dislocation itself is rarer and sometimes missed.
It is rarer than anterior, yes. And it can be notoriously easy to miss on initial assessment if you're not specifically thinking about it.
What's the clue?
The history is often the biggest clue. Posterior dislocations are typically caused by events that force the arm into internal rotation and adduction, things like electric shocks, epileptic seizures, or sometimes very severe physical restraint, like being held in a half Nelson wrestling hold.
Why is it easy to miss on a standard X-ray, the front to back view?
Because on a standard AP, anterior-posterior view, the shoulder can look deceptively normal or show only very subtle signs that the unwary, as the source puts it, might overlook. Things like the normal overlap between the humeral head and glenoid looking a bit odd.
So you need a different view.
Absolutely. An axial view looking either up the arm from below or down from above is crucial. It clearly shows the humeral head sitting behind the glenoid socket. You might also see an impaction fracture on the front of the humeral head in this case, a reverse Hill-Sachs. A high index of suspicion, especially based on that specific type of injury mechanism, is vital.
How is a posterior dislocation treated? Is it hard to put back in?
Reduction can sometimes be difficult, especially if the front of the humeral head has become significantly impacted or jammed against the back rim of the glenoid. That's sometimes called a locked posterior dislocation, and it might require open surgery to reduce. The source describes a closed reduction technique involving gentle traction, abduction, and internal rotation, followed by careful external rotation.
And after it's reduced?
After reduction, the shoulder is typically immobilized in an external rotation brace for several weeks to allow the posterior structures to heal in a better position.
Okay. Let's go back to the second category of instability you mentioned. Atraumatic instability. No major injury involved here.
Right. With atraumatic instability, there isn't usually a history of a single significant injury that caused the first episode. It often just starts gradually, and it's frequently multidirectional.
Loose in all directions?
Often feels loose moving forwards, backwards, and downwards, inferiorly. Patients with this type usually experience subluxations, partial slips, more often than full dislocations, and they are often able to reduce the joint themselves when it slips out.
What do you look for on examination in these patients?
These patients often have signs of generalized ligamentous laxity throughout their body. The source mentions the Baton score, which is a simple set of maneuvers to check for hypermobility in other joints.
Okay.
On shoulder examination, the apprehension test might be positive, but often in multiple directions, not just anteriorly. You can often physically translate or glide the humeral head noticeably forwards and backwards within the socket. And pulling down gently on the arm might create a visible gap or dimple just below the acromion.
The dip.
Yeah, exactly. That's called the sulcus sign, and it indicates inferior laxity, looseness downwards. It's also important to look for any abnormal muscle firing patterns or overactive muscles, like maybe the pectoralis major, that the patient might be subconsciously using to try and hold their shoulder in place because the ligaments are loose.
How is atraumatic instability treated? Is it surgery?
The initial treatment, and often the most effective long-term treatment, is specialist physiotherapy. It's really key here.
What does the physio focus on?
The focus is very much on improving proprioception. That's the body's sense of where the joint is in space, and actively retraining the coordination and firing patterns of all the muscles around the shoulder girdle. Biofeedback techniques can sometimes be helpful. Strengthening specific stabilizing muscles like the rotator cuff and scapular stabilizers is also crucial.
And if intensive physiotherapy doesn't work?
If a prolonged course of really good, focused physiotherapy fails to stabilize the shoulder and the patient remains significantly symptomatic, then surgery might be considered. This usually involves procedures to tighten the loose joint capsule, often arthroscopically. But the techniques and maybe the outcomes can differ a bit from the surgery done for traumatic instability.
Okay. And finally, that third category, habitual dislocation, the voluntary kind.
Right. This is distinct because the dislocation, or more commonly subluxation, is voluntary. The person can actively cause their shoulder to slip out of joint themselves.
The party trick scenario.
Exactly. It's typically painless when they do it, and it's strongly associated with that generalized joint laxity we talked about.
What's the treatment for this, if they can just pop it out whenever they want?
The primary advice is actually quite simple. Stop doing it.
Just don't.
Yeah. Consciously avoiding the specific maneuver that causes the dislocation can, over time, allow the stretched capsule to tighten up somewhat on its own. Physiotherapy to strengthen the dynamic stabilizers, the muscles, is also helpful. But surgery
is usually avoided.
Yes, surgery is generally avoided in this group because it has a notoriously high failure rate. The underlying voluntary nature of the instability and the generalized tissue laxity makes surgical repairs much less likely to hold up long term.
Wow, okay. That's a really comprehensive tour of the shoulder complex.
Yeah.
An incredible amount of detail there.
Yeah.
Let's transition down the arm now and talk about the elbow joint.
Okay. The elbow. It might seem like a simple hinge joint compared to the shoulder.
Yeah, just bending and straightening.
Well, it does that very well. Flexion and extension primarily happen at the ulnohumeral articulation, where the ulna bone of the forearm meets the humerus. But the elbow is also crucial for rotating the forearm pronation, turning the palm down, and supination, turning the palm up.
Where does that happen?
That rotation involves the radial head spinning on the capitellum part of the humerus, the radiocapitellar joint, and also rotating against the ulna at the proximal radial ulnar joint, right there at the elbow. And of course, that works in concert with the distal radial ulnar joint down at the wrist and the membrane connecting the radius and ulna along their length. So it's key for positioning the hand effectively in space.
More complex than it looks at first glance. What about the important structures around the elbow, like nerves and arteries?
Yes, it's a busy anatomical intersection. At the front of the elbow crease, running from the inside medial to the outside lateral, you generally have the median nerve, then the brachial artery, the main blood supply to the forearm and hand, and then the radial nerve.
And the funny bone.
Yes, the ulnar nerve. Famously, it runs in a groove right behind the medial epicondyle, that prominent bony bump on the inside of your elbow. It's quite superficial there, which is why hitting it causes that unpleasant tingling or zapping sensation down to your little finger.
The source we're using mentions that conditions like tennis elbow and golfer's elbow are covered elsewhere.
That's right. Those common conditions are types of epicondylitis, which is essentially pain originating from the tendons where they attach to the bony epicondyles on either side of the elbow. This particular section focuses more on problems arising within the elbow joint itself, like arthritis, and also on nerve compression issues around the elbow.
Okay, so speaking of joint problems, let's look at arthritis in the elbow. Can it get RA like the shoulder?
Yes, rheumatoid arthritis can definitely affect the elbow. As it's a systemic inflammatory disease, the elbow joint lining, the synovium, can become inflamed, swollen, and over time it damages the cartilage and underlying bone.
What's done for end-stage RA in the elbow?
Surgical intervention is often needed eventually. Procedures might include excising the radial head, which often gets involved in RA, and removing the inflamed synovium, a synervectomy. This can help with pain and also improve forearm rotation. For more advanced destruction, elbow replacement or arthroplasty can provide significant pain relief and restore a good degree of function.
What about osteoarthritis, the wear and tear type in the elbow?
Elbow OA is also common, though perhaps less so than in the knee or hip. It can be primary, just developing over time, or secondary, maybe following a previous fracture or injury to the elbow joint. It's seen quite frequently in middle-aged men, especially those who have done heavy manual labor over many years.
What are the typical symptoms they experience?
Patients often complain of elbow pain, particularly with activity. They might describe a sensation of the joint locking or catching. Crepitus, that grinding or cracking sound or feeling, is common, and they usually develop restricted motion, especially losing those last few degrees of straightening the elbow fully, extension, and bending it fully, exflexion.
Any nerve issues common with elbow OA?
Yes, ulnar nerve symptoms, that tingling in the ring and little fingers, are actually quite common. This often happens because bone spurs, osteophytes, forming around the joint can irritate or compress the ulnar nerve as it passes behind that medial epicondyle.
What do you typically find on examination?
Restricted movement is a key finding, especially loss of terminal extension and flexion. Often, trying to force that end range movement causes pain, which is due to the bone spurs or thickened soft tissues physically bumping into each other. That's called impingement again. Forearm rotation, pronation, and supination might be less affected than in NRA, but you can often feel crepitus over the radiocapitellar joint during rotation, and specific tests like the grip and grind test can reproduce pain there.
How is elbow OA managed surgically if non-surgical approaches fail?
Well, fusion of the elbow, arthrodesis, is very rarely done for OA. It results in significant functional loss because you lose all bending and straightening. It's generally only considered for very heavy manual laborers, where having a strong, stable, pain-free elbow for lifting is the absolute priority over motion.
What about joint replacement for OA?
Elbow joint replacements are available, but they don't tend to tolerate heavy loads or high-impact activities as well as, say, hip or knee replacements. They are prone to loosening earlier if the person engages in heavy manual work, so they're more often used in lower demand patients or for conditions like RA.
So what other surgical options are there for OA?
A common approach for symptomatic OA is surgical debridement, sometimes called the lateral column procedure or an outer bridge Kashiwagi procedure variation.
What does that involve?
It basically involves cleaning out the joint, removing the impinging bone spurs from the front and back, trimming thickened capsule tissue, and removing any loose bodies floating around. The goal is to improve the range of motion and reduce that painful impingement at the ends of movement.
Any other options?
For issues specifically at the back of the elbow causing pain or blocking extension, techniques exist to remove olecranon osteophytes or drill out the olecranon fossa to create more space. Interposition arthroplasty is another concept, sometimes considered in younger patients, where tissue, like an Achilles tendon allograft, is placed into the joint to resurface it. But the source mentions concerns about potential bone loss long term. Prosthetic joint replacement, as we said, gives predictable pain relief, but activity restrictions are important.
You mentioned loose bodies. They sound like they would cause distinct mechanical symptoms like locking.
They certainly do. These are little fragments of cartilage or bone that break off and float freely within the joint space.
Where do they come from?
Common causes include osteoarthritis, as we just discussed, spurs breaking off. Also, a condition called osteochondritis dissecans, often seen in younger people, sometimes called Panner's disease after Hans Jessen Panner, where a piece of bone and cartilage loses its blood supply and can separate. Or a condition called synovial chondromatosis, where the joint lining itself starts producing multiple small cartilage bodies.
What do patients complain of?
They typically describe sudden, sharp episodes of pain and locking where the elbow gets stuck. They often have to manipulate or shake their arm to get it to unlock and relieve the pain.
How are they diagnosed and treated?
Plain X-rays can often show calcified loose bodies. CT or MR arthrograms are more sensitive, especially for cartilage-only fragments, showing them as filling defects. The standard treatment is arthroscopic clearance, using keyhole surgery to go in, find all of the loose bodies, and remove them. This usually gives very good results in relieving those mechanical symptoms.
Okay, shifting from inside the joint to the tissues around it. Olecranon bursitis, that's that noticeable swelling right on the point of the elbow, isn't it?
Exactly, very common. The olecranon bursa is a thin, fluid-filled sac that normally allows the skin to glide smoothly over the bony point of the elbow, the olecranon process. When it gets inflamed bursitis, that area becomes red, warm, swollen, and often quite tender or painful.
Can it get infected?
It can, so it's important to consider septic bursitis. However, typically in simple, non-infected bursitis, the signs and symptoms are pretty much confined just to that superficial area over the back of the elbow. The patient usually still has a reasonable range of motion in the elbow joint itself, maybe from 30 to 130 degrees, without severe pain deep in the joint.
How's it usually treated?
Most cases of simple olecranon bursitis settle down with rest, avoiding pressure on the elbow, and anti-inflammatory medications. If there are signs of infection, like fever or spreading redness, then antibiotics are necessary. If there's obvious pus collection, it might need to be drained. Sometimes chronic recurrent bursitis can lead to thickening of the bursa lining or even the formation of little calcific nodules within it, which can be surgically excised if they become persistently troublesome.
Let's talk about nerve compression at the elbow now. The ulnar nerve seems particularly vulnerable there.
Yes, the ulnar nerve is most commonly compressed right where it passes behind the medial epicondyle in that channel known as the cubital tunnel.
Why there?
It's a relatively tight space, and the nerve is quite superficial. Bending the elbow stretches the nerve and narrows the tunnel, so prolonged or repetitive elbow flexion can contribute. Other less common sites mentioned in the source include higher up in the arcade of Struthers, named after Sir John Struthers, or a bit lower down where the nerve passes between the two heads of the flexor carpi ulnaris muscle in the forearm.
What symptoms does this compression cause? Where does the patient feel it?
The classic symptoms are tingling and numbness, pins and needles, affecting the little finger and the ulnar side, the half closer to the little finger of the ring finger.
What about on examination?
You often find a positive Tinel sign named after Jules Tinel. That's where tapping gently over the nerve behind the medial epicondyle reproduces that tingling or electric shock sensation down into those specific fingers. In more advanced or long-standing cases, you might start to see visible wasting or atrophy and weakness of the small intrinsic muscles within the hand that are supplied by the ulnar nerve.
Which muscles are those?
Particularly the muscles on the pinky side of the palm, the hypothenar muscles, and the muscles between the metacarpal bones, the interossae. Weakness here affects grip strength and fine motor control. There's a specific test called Froment's sign, named after Jules Froment.
What does that show?
It checks for weakness of the adductor pollicis muscle, which pulls the thumb towards the palm and is supplied by the ulnar nerve. If that muscle is weak, and you ask the patient to pinch a piece of paper firmly between their thumb and the side of their index finger, they compensate by excessively bending the joint at the tip of their thumb. They're using a different thumb flexor muscle supplied by the median nerve to try and hold on.
Are nerve conduction studies useful?
They can be. Nerve conduction studies can help confirm the diagnosis by showing slowing of the nerve signal as it passes through the cubital tunnel. However, the source notes they can sometimes be normal, especially in early or intermittent cases, so a normal study doesn't completely rule it out if the clinical picture is convincing. X-rays are also usually done to check for any bony abnormalities like spurs or loose bodies that might be contributing to the nerve compression.
How is ulnar nerve compression at the elbow treated?
For milder symptoms, especially those that mainly occur at night, conservative measures are tried first. Wearing a night splint that keeps the elbow straight, preventing prolonged flexion during sleep, can often help significantly.
And if that's not enough, or if there's weakness?
If symptoms persist despite splinting, or if there's objective evidence of muscle weakness or wasting, then surgery is usually recommended to prevent permanent nerve damage. The most common procedure is a simple decompression.
Just opening up the tunnel.
Exactly, surgically opening up the cubital tunnel and any other potential tight spots along the nerve's path in that area to give the nerve more space and relieve the pressure. Sometimes, particularly if there's a significant valgus deformity at the elbow, meaning the elbow angles outwards, or if the nerve seems unstable and tends to pop out of its groove after decompression, the surgeon might opt to move the nerve to the front of the medial epicondyle. That's called an anterior transposition.
Okay, we've journeyed down from the shoulder through the elbow. Let's turn our attention now to the hand and wrist. These are arguably the most functionally critical parts of the upper limb for how we interact with the world, aren't they?
Absolutely. The hand and wrist truly work in concert. The source really emphasizes the importance of having a stable yet mobile wrist. It acts as the foundation, the platform that positions the hand effectively for all the incredibly diverse tasks it performs.
And the source mentions different types of grips.
Yes, it describes several functional grip patterns. The fine pinch grip, using just the tips of the thumb and index finger. The key pinch, using the pad of the thumb against the side of the index finger, like holding a key. The tripod pinch using the thumb, index, and middle fingertips together for more dexterity. The hook grip using just the flexed fingers without the thumb, like carrying a shopping bag. And the power fist using the whole hand for maximum force. A good wrist is essential for all of these.
Given the sheer complexity of the hand, the clinical history and the physical examination must be incredibly detailed.
Oh, absolutely paramount. You need to understand exactly how the person uses their hands day to day, their occupation, any hobbies, which hand is dominant. Then you need to pin down their symptoms. Is it pain, swelling, stiffness, a feeling of instability, or nerve sensations like pins and needles or numbness? And a crucial point the source makes is to try and identify which specific symptom is causing the patient the greatest functional deficit.
Why is that important?
Because mild stiffness might be annoying, but severe nerve pain that stops you sleeping might be much more disabling, even if the hand looks okay. So you target the main problem. You also absolutely need to consider comorbidities.
Other health problems.
Yes, things like diabetes, for example, which is very strongly associated with nerve problems like carpal tunnel syndrome, or inflammatory conditions like rheumatoid arthritis.
What does the hand examination itself involve? And it seems like there's so much to check.
It's very systematic. You need to assess sensation, circulation, movement, and strength. Start with perfusion, look at the color and warmth of the hand, check the capillary refill, feel for pulses if necessary. Sensation testing is vital, carefully mapping out the areas supplied by the three major nerves.
Median, ulnar, radial.
Exactly. The median nerve typically supplies the palm side of the thumb, index, middle, and the radial half of the ring finger. The ulnar nerve supplies the palm side of the little finger and the ulnar half of the ring finger, plus a variable area on the back of the hand. And the radial nerve mainly provides sensation to the back of the hand, particularly the first dorsal web space between the thumb and index finger.
Like a sensation, circulation.
What about motor function, movement, and strength?
You need to check motor function. Key muscles to test include the abductor pollicis brevis at the base of the thumb for the median nerve, and the first dorsal interosseous muscle between the thumb and index finger for the ulnar nerve. And remember, the radial nerve is critical for extending the wrist. You can't make a strong grip without good wrist extension.
How do you assess movement? You usually start by looking at broad, functional movements. Ask the patient to make a full fist, then open the hand wide, spread the fingers apart, bring them together. Then you assess the range of motion at the wrist. If needed, you can go on to examine the function of individual muscles or tendons. As the patient moves, you have to watch carefully for any asymmetry or any abnormal rotation of the fingers as they flex or extend. Rotational malalignment can indicate underlying problems like a fracture that's healed crookedly. And of course, there are many, many special tests for specific ligaments, tendons, and nerves in the hand and wrist.
What about investigations? What imaging or tests are used for hand problems?
Plain X-rays are still the standard first step for looking at bones and joints, checking for arthritis, fractures, bone tumors. Electrophysiological studies, like nerve conduction studies and EMG, are used to evaluate nerve function, particularly for suspected compressions like carpal tunnel syndrome, although they can sometimes be normal in early stages. Ultrasound has become increasingly valuable.
For the hand, too.
Yes, especially for visualizing soft tissues like tendons, you can watch them glide dynamically as the patient moves. It's also good for assessing tendon instability or tears, and because the tissues are thin, it can detect early signs of joint inflammation or erosions. MRI is generally reserved for specific situations like suspected avascular necrosis of wrist bones, complex ligament injuries, or getting detailed images of soft tissue tumors.
The source uses a strong phrase. It describes swelling and stiffness in the hand as the arch enemy of rehabilitation.
That's a really powerful and accurate description. It's absolutely true. After any significant hand injury, surgery, or even infection, the hand's natural response is to swell up.
And that swelling causes problems.
Yes, because the hand tends to adopt a position of comfort when swollen, which is unfortunately a position of disaster long term. That position is typically wrist flexion, the main knuckles, MCP joints, held straight in extension, and the middle finger joints, IP joints, held bent in flexion.
Why's that bad?
Because if the hand stays in that position while it's swollen and healing, the crucial collateral ligaments around the joints can shorten and contract, the joint capsules thicken, and everything becomes fibrous and stiff. This can lead to permanent contractures and a major loss of hand function.
So preventing that permanent stiffness is absolutely critical from the start.
Absolutely essential. The source outlines 3 key principles of early management, summarized nicely. Elevation, keeping the hand raised, ideally above the level of the heart, uses gravity to help reduce swelling. Splintage, using splints to position the hand in the position of safety or intrinsic plus position.
What's that position?
That's the opposite of the disaster position. The wrist is held slightly extended. The main knuckles, MCPs, are bent forward, flexed, and the finger joints, IPs, are kept straight, extended. This position keeps the important collateral ligaments stretched and helps prevent those devastating contractures. And thirdly, movement encouraging early, gentle movement, as much as pain allows, helps to pump swelling out of the tissues and maintain joint suppleness. Elevation, splintage, movement, ESM.
ESM, elevation, splintage, movement. Got it. Okay, let's move into some specific conditions affecting the hand and wrist, starting with an injury to the thumb's ulnar collateral ligament.
Right, the UCL of the thumb. This ligament is on the inside aspect of the thumb's metacarpophalangeal MCP joint, the main knuckle joint of the thumb. It's really crucial for providing stability during pinching activities.
How does it get injured?
It can happen in two main ways. Chronic overuse or repeated minor injuries can gradually stretch the ligament out, leading to instability and weakness of pinch. This is often called gamekeeper's thumb, from the historical association with gamekeepers wringing the necks of birds. Or, more commonly now, an acute injury happens from a sudden, forceful abduction of the thumb, bending it forcefully outwards and backwards away from the hand.
Like falling on skis.
Exactly. Classically seen in skiers when they fall and their thumb gets caught in the ski pole strap, hence the term skier's thumb for the acute rupture.
When did this injury need surgery?
The key factor is the degree of instability. If, on clinical examination, the joint opens up significantly on that ulnar side when you apply a gentle valgus stress, pushing the thumb outwards, then surgical repair is usually recommended.
Why can't it just heal in a cast?
Because sometimes a piece of tissue called the adductor aponeurosis, which is part of the thumb adductor muscle, can get flipped over the torn end of the ligament and become trapped between the ligament ends. This is called a Steiner lesion. It physically prevents the ligament ends from coming back together to heal naturally. The source shows diagrams of this. If a Steiner lesion is present, or if there's significant instability, surgery is needed to put the ligament back where it belongs and repair it.
Okay. Moving to the wrist now. The triangular fibrocartilage complex, or TFCC, that sounds complicated. What is it?
It is a bit complex anatomically. It's a structure located on the ulnar pinky finger side of the wrist, sort of nestled between the end of the ulna bone and the first row of carpal bones. It's made up of several components, including strong ligaments, the ulnocarpal ligaments, part of the sheath for the ECU tendon, and importantly, a meniscus-like disc of fibrocartilage.
What does it do?
Its main jobs are to help stabilize the distal radial ear joint, DRUJ. That's where the radius and ulna meet at the wrist, allowing forearm rotation, and also to help transmit forces across the ulnar side of the wrist.
How does it get damaged?
The TFCC can be injured by trauma, often a fall onto an outstretched hand, especially with a twisting motion, or it can undergo degenerative tearing over time just from wear and tear.
What symptoms does a TFCC tear cause?
The main symptom is usually pain on the ulnar side of the wrist, often made worse by gripping or twisting movements, like opening a jar or turning a doorknob. Sometimes patients also report a clicking sensation or a feeling of instability in the distal radial ulnar joint.
How are TFCC problems diagnosed and treated?
Diagnosis is often based on the clinical history and examination findings. An MRI arthrogram with contrast injected into the wrist joint is often the best imaging test to visualize the TFCC and identify tears. Wrist arthroscopy, looking inside the joint with the camera, is considered the gold standard for both diagnosis and treatment.
What are the treatment options?
It depends on the type and location of the tear. Tears on the outer edge, the periphery, often have a better blood supply and can sometimes be repaired surgically, either through an open incision or arthroscopically. Tears in the central avascular portion of the disc, which are often degenerative, don't heal well if repaired, so they are typically treated by arthroscopic debridement, just trimming away the torn, unstable fragments.
Let's talk about hand infections now. You mentioned earlier they can be very serious.
They absolutely require prompt diagnosis and treatment because of the hand's intricate anatomy and the potential for rapid spread and devastating functional loss.
What's the most common type?
The source states the commonest hand infection is probably paronychia. That's an infection around the fingernail bed, in the nail fold.
What does it look like?
You'll typically see redness, swelling, and tenderness right alongside the nail, often with pus visible beside or tracking under the nail plate itself. Treatment usually involves making a small incision to drain the pus, along with antibiotics. Sometimes, a portion of the nail might need to be removed to allow adequate drainage.
What about a felon? That sounds serious.
A felon is more serious, yes. It's a deep abscess located within the tight fibrous compartments of the fingertip, pulp the fatty pad on the palm side of the fingertip. Because those compartments don't stretch easily, the pus builds up under considerable pressure, causing intense throbbing pain. There's also a significant risk of the infection spreading to the underlying bone, causing osteomyelitis.
How is a felon treated?
Urgent incision and drainage is required, typically through a midline incision on the pulp, being careful not to cross the flexion crease. Intravenous antibiotics are also usually necessary.
And flexor tendon sheath infections, you said those are emergencies.
Yes, acute suppurative flexor tenosynovitis is considered a true surgical emergency. The source highlights Canavel's 4 cardinal signs, named after Alan B. Canavel, which are the classic indicators. 1, the finger is held in a slightly bent, flexed position. 2, there's uniform, symmetrical swelling along the entire length of the finger. 3, there's exquisite tenderness specifically over the course of the flexor tendon sheath on the palm side. And 4, there's severe pain when you passively try to straighten the patient's finger.
Why is it so dangerous?
Because the infection is within the synovial sheath that surrounds the flexor tendons. This sheath acts like a closed tunnel, allowing the pus to spread rapidly along its length. The pressure builds up, cutting off blood supply to the tendons, potentially leading to tendon necrosis, death. And understanding the anatomy is crucial here. The sheaths for the index, middle, and ring fingers are usually self-contained, ending in the palm. But the sheaths for the thumb and the little finger often communicate with larger bursae, the radial and ulnar bursae, that extend up into the wrist and forearm.
So infection in the thumb or little finger can spread much further.
Exactly. It can track up into the wrist, causing a horseshoe abscess.
How are these tendon sheath infections treated?
Immediate surgical intervention is required. This involves open irrigation of the entire tendon sheath. Usually small incisions are made at the proximal and distal ends of the sheath, and a small catheter or tube is inserted to allow thorough flushing with saline solution. This is combined with broad-spectrum intravenous antibiotics. In very severe cases, if the finger's viability is threatened, the entire finger might need to be opened up surgically. Untreated, these infections lead to devastating consequences. Dense adhesions scarring the tendons down, tendon rupture, tissue necrosis, and widespread infection.
Are there other, maybe less common types of infections that can affect the hand?
Yes, the source mentions mycobacterial infections like tuberculosis, TB. TB can affect the tenosynovium, tendon sheaths, joints, or bones in the hand and wrist. A notable presentation is something called a compound palmar ganglion, which is chronic tuberculous tenosynovitis, causing swelling in the palm that bulges both above and below the transverse carpal ligament, sometimes mimicking carpal tunnel syndrome. Diagnosis requires a biopsy of the affected tissue. Treatment involves extensive surgical removal of the infected synovium, synovectomy, combined with a long course of specific anti-tuberculous antibiotics.
What about deep space infections?
These occur in the potential spaces within the palm itself, or sometimes in the web spaces between the fingers. The whole hand can become markedly swollen, red, and tender as pus collects in these deep compartments. Treatment involves surgical incision and drainage of these spaces, sometimes requiring incisions on both the palm and the back of the hand to ensure adequate drainage, along with washout and antibiotics. Ultrasound or MRI can be helpful beforehand to delineate exactly where the pus is collected.
Okay. Arthritis is another major cause of pain and disability in the hand and wrist.
Let's start with rheumatoid arthritis again.
Right. RA often has very characteristic and sometimes dramatic manifestations in the hands and wrists. The classic symptoms include prolonged morning stiffness, often lasting more than an hour, symmetrical arthritis affecting the same joints on both sides, joint swelling, the potential for significant deformities, and sometimes the presence of rheumatoid nodules under the skin. The source includes a table listing diagnostic criteria often used, including blood tests like rheumatoid factor and specific radiographic changes.
What are the key differences you see on an X-ray between RA and osteoarthritis in the hand? The source contrasts them. Yes, it provides a helpful comparison. In RA, you typically see things like periarticular osteoporosis. The bone around the joints looks thin and washed out. You see joint space narrowing due to cartilage destruction. Characteristic marginal erosions develop little bite marks, where the inflamed pannus is eating away at the bone right at the edge of the joint. Soft tissue swelling is often quite pronounced. Deformities and malalignment can become severe. And sometimes joints can fuse together spontaneously, ankylosis.
And how does that compare to OA on X-ray?
In OA, you're more likely to see subchondral sclerosis. The bone just beneath the cartilage looks denser and whiter. You might see subchondral cysts, little fluid-filled holes in the bone. Joint space narrowing is also present, of course, but instead of erosions, you see marginal osteophytes, bone spurs growing at the joint edges. Soft tissue swelling and deformity are usually less pronounced than in RA, and ankylosis is much less common.
And that pannus tissue in RA, the inflamed joint lining, that's what causes all the destruction.
Yes, that proliferative inflamed pannus is highly destructive. It releases enzymes that directly erode the cartilage, bone, ligaments, and even tendons, leading progressively to pain, instability, deformity, and significant loss of function.
What are some of the typical deformities seen in the RA hand?
There are several classic ones described and often illustrated. The boutonniere deformity, French for buttonhole, is where the middle finger joint, PIP, is stuck in flexion, and the end joint, DIP, hyperextends. The swan neck deformity is the opposite. The PIP joint hypoextends and the DIP joint flexes. At the wrist, there's often a characteristic pattern where the entire wrist drifts towards the thumb side, radially, with a compensatory drift of the fingers towards the pinky side, ulnar deviation, at the main knuckle joints, MCPs. Extensor tendons on the back of the hand can rupture, often starting with the little finger and progressing across towards the index finger. This pattern is known as Von Jackson syndrome, after Oliver J. Von Jackson. Flexor tendons on the palm side can also develop synovitis or rupture. The MCP joints themselves are particularly prone to becoming flexed, deviated towards the ulna, and eventually subluxating or dislocating completely. The wrist often shows that radial deviation, rotation, supination of the carpal bones, a prominent and sometimes unstable distal ulna head, Kupffer ulna, and inflammation of the extensor tendon sheaths over the back of the wrist.
Wow, that sounds like you have severely intact function.
Absolutely. All these changes severely impact the ability to perform everyday tasks requiring pinch strength, grip, or fine motor control, like opening jars, turning keys, or buttoning clothes.
So the goal of treatment isn't just about how it looks, but restoring function and relieving pain.
Precisely. As the source emphasizes, surgical treatment decisions are primarily driven by the patient's level of pain and functional disability, not just by the cosmetic appearance of the deformity, although that can be a factor too. Managing the RA hand often involves a combination of medical management for the systemic disease, hand therapy, splinting, and potentially a series of surgical procedures over time.
What's the approach to surgery? Is there an order?
There's a general surgical axiom mentioned. Often you start proximally at the wrist and work your way distally towards the fingers. And sometimes you might alternate between procedures that sacrifice some motion to gain stability and pain relief, like fusions, and procedures that aim to preserve or restore motion, like joint replacements or tendon reconstructions.
Can you list some of the common surgical procedures used for the RA hand?
Sure. Common procedures include synovectomy, removing the inflamed joint lining or tendon sheath lining. Release of trigger fingers, or decompression of compressed nerves like the median nerve in the carpal tunnel. Excision of the distal ulna bone, the Darack procedure, can relieve pain at the wrist and prevent extensor tendon ruptures, although in younger, more active patients, a constrained distal ulna replacement might be considered. Arthrodesis, or fusion, is a very reliable procedure for pain relief and stability. It's often used for the wrist, the thumb joints, or sometimes the small finger joints. Although it eliminates motion at that specific joint, it creates a stable, painless platform for overall hand function.
What about joint replacements?
Joint replacements, or arthroplasties, are available for the MCP joints and the PIP joints. These aim to relieve pain while maintaining or improving motion. Total wrist arthroplasty is also an option for severe wrist destruction, providing pain relief and preserving some degree of wrist motion, though maybe not as much as a normal wrist. And finally, for ruptured tendons, various reconstruction procedures can be done, such as tendon transfers or sometimes using fusions to compensate for the lost tendon function.
Okay, let's shift focus now to osteoarthritis, OA, in the hand and wrist. Where does it typically occur?
In the wrist, OA most commonly affects the main radiocarpal joint, where the radius meets the first row of carpal bones. It can be primary or more often secondary to previous injuries like scaphoid fractures or ligament tears. If non-surgical treatment fails, surgical options include fusing just part of the wrist, limited wrist arthrodesis, fusing the entire wrist, total wrist arthrodesis, or potentially total wrist replacement in selected patients.
And in the hand itself, OA seems very common there, especially those knobby finger joints people associate with aging.
Yes, hand OA is extremely common, particularly in women. The most frequently affected joints are the distal interphalangeal DIP joints, those joints closest to the fingertips. The bony enlargements that form there are called Heberden's nodes, named after William Heberden. The proximal interphalangeal PIP joints, the middle joints of the fingers, can also be affected, and the nodes there are called Bouchard's nodes, named after Charles Jacques Bouchard. And another very, very common site for symptomatic OA is the base of the thumb, the carpometacarpal CMC joint.
Does how bad the nodes look always match how much pain someone has?
Not necessarily. The source makes an interesting point that there's often a poor correlation between the radiographic appearance or the size of the nodes and the severity of the patient's symptoms. Some people have very knobby fingers with little pain, while others have significant pain with relatively minor changes on X-ray.
How is hand OA typically managed?
Non-surgical options are the mainstay initially. Activity modification, splinting, especially for the thumb CMC joint, hand therapy exercises, and occasionally steroid injections into the affected joints, again, particularly effective for the thumb CMC joint.
And if surgery is needed, what are the options for finger joint OA?
For the DIP and PIP joints, arthrodesis fusion is a very common and reliable surgical option. It completely eliminates the pain from the arthritic joint. Although it sacrifices motion at that specific joint, overall hand function is often surprisingly well preserved, especially for DIP joint fusions. Joint replacements are also available for the PIP and MCP joints, aiming to relieve pain while preserving motion, but they may not be as durable as fusions, especially in active individuals.
What about that painful thumb base arthritis, the CNC joint?
For severe thumb CMC joint OA that doesn't respond to conservative measures, a very common and successful surgical procedure is excision arthroplasty. This involves removing the trapezium bone, which is one of the small carpal bones at the base of the thumb that forms the arthritic joint. Often a tendon is used to fill the space and create a cushion. This procedure, often called trapeziectomy, is excellent for pain relief and generally maintains good thumb motion and function.
Are there other forms of arthritis besides RA and OA that might show up in the hand?
Yes, the source briefly mentions a couple of others. Psoriatic arthritis, associated with the skin condition psoriasis, can affect the hand joints, often the IP joints, both PIPs and DIPs. It tends to be asymmetrical, can cause a characteristic sausage-like swelling of an entire finger, dactylitis, and is often associated with nail changes like pitting. Gout is another important one. It's caused by the deposition of monosodium urate crystals in the joints. It typically causes acute attacks of extremely severe pain, swelling, redness, and warmth in a joint, often the big toe, but the hand and wrist are also common sites. Chronic gout can lead to the formation of tophi, which are visible or palpable collections of urate crystals under the skin or around joints.
Can it be hard to tell gout from an infection?
It can be very difficult, especially during an acute attack, as both cause a hot, red, swollen, painful joint. The definitive diagnosis for gout relies on aspirating fluid from the affected joint and examining it under a special polarized light microscope. Finding the characteristic needle-shaped, negatively birefringent monosodium urate crystals is diagnostic. Just checking blood uric acid levels isn't always reliable, as levels can actually be normal during an acute gout flare.
Okay, let's move on to a very different type of hand condition, Dupuytren's contracture. This one has very distinctive features and often comes up in exams, apparently.
It certainly is a classic condition. Dupuytren's disease, or contracture, is primarily a genetic condition, often following an autosomal dominant pattern of inheritance. It's most common in people of Northern European descent, typically affecting men more often than women, usually starting in their 50s to 70s.
So it runs in families.
A family history is common, yes, but many cases appear sporadically without a known family link. There are also some known associations with other factors, though the exact relationships aren't always clear. Things like smoking, previous hand trauma, epilepsy, hypothyroidism, alcoholic liver cirrhosis, and possibly even HIV infection.
What are the characteristic features? What do you actually see?
It starts with the development of firm nodules, usually painless, in the palm of the hand. Over time, these nodules can thicken and merge, forming palpable cords that run longitudinally out towards the fingers. You might also see puckering or dimpling of the overlying skin as it gets pulled down by the disease process in the underlying fascia.
And these cords pull the fingers down.
Exactly. As the cords mature and contract, they gradually pull the affected fingers down into a bent, flexed position at the MCP joint, the knuckle, and or the PIP joint, the middle joint. It most commonly affects the ulnar side of the hand. The ring and little fingers are most frequently involved.
What about those knuckle pads the source mentions? Garrett's pads.
Yes, Garrett's knuckle pads are sometimes seen in patients with more severe or aggressive forms of Dupuytren's disease. Named after Sir Archibald Edward Garrett, these are thickened, fibrous pads that develop on the skin over the back of the PIP joints. They're part of the same underlying fibromatosis process.
And this same process can happen elsewhere in the body.
Yes, the same type of abnormal fibrous tissue proliferation can occur in other locations. On the penis, it causes Parodin's disease, leading to penile curvature, named after François de la Péronie. On the soles of the feet, it causes Lederhose disease, forming nodules in the plantar fascia, named after Georg Lederhose.
When is treatment actually indicated for Dupuytren's contracture in the hand? When should something be done?
The main indication for intervention is functional limitation caused by the contracture. The classic, simple clinical test is the tabletop test.
How did that work?
You ask the patient to try and lay their hand completely flat, palm down, on a tabletop. If they can't get their palm flat because one or more fingers are held up by a fixed flexion contracture at the MCP joint, that's generally considered an indication to discuss treatment. Also, if a significant flexion contracture develops at the PIP joint, intervention is often recommended sooner because PIP contractures are notoriously more difficult to correct fully the longer they are left.
What are the treatment options? Is it always surgery?
Not always, especially for milder contractures. Non-surgical options have become more common. Needle fasciotomy or needle aponeurotomy is one. Under local anesthetic, a needle is used to repeatedly puncture and cut the tight cord through the skin, allowing the finger to straighten. Another option is injection of collagenase enzymes.
Enzymes to dissolve the cord.
Exactly. Injecting specific enzymes derived from bacteria directly into the Dupuytren's cord can break down the collagen fibers that make it up. A day or so later, the finger is manipulated to rupture the weakened cord.
And for more severe cases?
More severe or extensive contractures usually require surgical management. The standard surgical approach is a fasciectomy, which involves carefully dissecting out and excising the diseased cords. This requires meticulous dissection because the digital nerves and arteries, which supply sensation and blood to the fingers, are often intimately intertwined with or displaced by the cords and must be protected from injury.
What about closing the skin afterwards? If the finger's been bent for a long time?
Skin closure after releasing significant contractures can be challenging because the skin itself may have contracted. Sometimes simple closure is possible, but often techniques are needed to lengthen the skin, like using Z-shaped incisions, Z-plasties. In some cases, areas might need to be covered with full-thickness skin grafts, often taken from the inner forearm where the skin is hairless. Occasionally, small areas are even left open to heal gradually on their own, healing by secondary intention.
What about very advanced, long-standing contractures?
In late-stage Dupuytren's, especially with severe fixed flexion contractures at the PIP joint, the joint itself may have become secondarily stiff and arthritic. In these situations, simply excising the cord might not restore useful function to the finger. If a severely contracted finger is functionless and just getting in the way, preventing useful function of the rest of the hand, amputation of that digit might unfortunately be considered as a salvage procedure.
Okay. Let's look at some common tendon disorders in the hand now. Trigger finger or trigger digit seems very common.
Extremely common. Trigger digit, or stenosing tenosynovitis, causes a painful clicking, catching, snapping, or locking sensation when the patient tries to bend, or more often, straighten the affected finger or thumb.
What causes that catching?
It's essentially due to a size mismatch between the flexor tendon gliding through its sheath and the entrance to that sheath, specifically a thickened band called the A1 pulley, which sits right at the base of the finger in the palm over the MCP joint. Either the tendon itself develops a nodule, or the pulley sheath becomes thickened and narrowed, so the tendon gets stuck as it tries to glide through.
What do you find on exam?
You'll usually find tenderness when you press directly over that A1 pulley area. You might even be able to feel the nodule on the tendon clicking or popping as the patient moves their finger.
How is trigger finger treated?
The first line of treatment is usually a steroid injection directly into the tendon sheath at the level of the A1 pulley. This is often very effective in reducing the inflammation and swelling, allowing the tendon to glide smoothly again.
And if the injection doesn't work?
If 1 or 2 injections fail to provide lasting relief, then a minor surgical procedure is done. Under local anesthesia, a small incision is made in the palm, and that tight A1 pulley is surgically divided or released. This opens up the tunnel, allowing the tendon to glide freely. Care must be taken not to release too much of the pulley system further down the finger, which could cause the tendon to bowstring away from the bone. The source also notes that trigger digits occurring in infants, especially trigger thumb, often tend to resolve spontaneously without treatment.
Okay. Another common tendon issue affects the wrist on the thumb side. De Quervain's disease.
Yes, de Quervain's tenosynovitis. This is inflammation specifically affecting the tendons and the synovial sheath lining of the first dorsal wrist extensor compartment.
Which tendons run there?
Two tendons that control the thumb, the abductor pollicis longus, APL, and the extensor pollicis brevis, EPB. And they run together through this tight fibrous tunnel on the radial side of the wrist, just near the base of the thumb.
Who tends to get this?
It's particularly common in middle-aged women. It's often associated with activities involving repetitive thumb abduction or gripping, and sometimes related to hormonal changes like during pregnancy or postpartum. It's sometimes called new mother's wrist or mommy thumb. It can also be associated with inflammatory arthritis like RA.
What are the symptoms?
The main symptom is pain on the radial side of the wrist, near the bony prominence called the radial styloid. Tenderness and sometimes visible swelling are present over that first dorsal compartment.
Is there a specific test for it?
Yes. The classic diagnostic test is Finkelstein's test, described by Fritz de Quervain and also Harry Finkelstein. You ask the patient to tuck their thumb into their palm, then make a fist over the thumb, and then gently bend their wrist downwards towards the little finger side, ulnar deviation. This maneuver stretches the APL and EPB tendons within their tight compartment and typically reproduces sharp pain right over the radial styloid if de Quervain's is present.
How is de Quervain's treated?
Non-surgical treatment is usually tried first. This includes things like non-steroidal anti-inflammatory drugs, NSAIDs, resting the thumb and wrist with a splint, often a thumb spica splint, and steroid injections directly into that first dorsal compartment. The injections are often very effective.
And if those don't work?
If symptoms persist despite good conservative management, then surgery is an option. The surgery involves making a small incision over the first dorsal compartment and surgically releasing the extensor retinaculum, the fibrous tissue forming the roof of the tunnel, to decompress the APL and EPB tendons and give them more space to glide. It's important during surgery to make sure that all the tendon slips are released, as the APL tendon often has multiple separate bundles within the compartment, and sometimes the EPB is in its own little subcompartment.
Okay. Compressive neuropathies, nerves getting squeezed, are obviously very common in the upper limb. Carpal tunnel syndrome is probably the most famous one.
By far the most common compressive neuropathy. Carpal tunnel syndrome, or CTS, is caused by compression of the median nerve as it passes through the carpal tunnel in the wrist.
What exactly is the carpal tunnel?
It's a narrow passageway on the palm side of the wrist. The floor and sides are formed by the carpal bones, and the roof is formed by a thick, strong ligament called the transverse carpal ligament. The median nerve and all the flexor tendons to the fingers pass through this tunnel.
Why does the nerve get compressed?
In the majority of cases, it's idiopathic, meaning we don't find a specific structural cause. The tunnel just seems too tight for the contents. However, CTS is strongly associated with a number of conditions that can increase the volume within the tunnel or make the nerve more susceptible, things like diabetes, thyroid disorders, especially hypothyroidism, alcoholism, amyloidosis, inflammatory arthritis like RA, fluid retention during pregnancy, obesity, and sometimes wrist fractures that narrow the tunnel.
What symptoms do patients typically report with CTS? What do they feel?
The hallmark symptom is tingling, numbness, or a pins and needles sensation affecting the distribution of the median nerve in the hand.
Which fingers are those again?
Typically the palm side of the thumb, the index finger, the middle finger, and the radial half, the thumb side, of the ring finger. The little finger is usually spared as it's supplied by the ulnar nerve.
When are the symptoms usually worst?
Symptoms are often worst at night. Patients frequently report being woken from sleep by the numbness or tingling, and they find relief by shaking their hand vigorously out over the side of the bed, the flick sign. They might also notice clumsiness during the day, difficulty with fine motor tasks like doing up buttons or picking up small objects, and sometimes a tendency to drop things, especially heavier objects. Symptoms are often bilateral, affecting both hands, though usually one is worse than the other.
What specific signs do you look for on examination?
In severe, long-standing chronic cases, you might see visible wasting or flattening of the muscles at the base of the thumb, the nor eminence. There might also be measurable weakness of the abductor pollicis brevis muscle, which is a key thunar muscle supplied by the median nerve. Several provocative tests can be used to try and reproduce the symptoms.
Like Tinnell's.
Yes, Tinnell's sign involves tapping gently over the median nerve at the wrist crease to see if it elicits tingling in the fingers. Phelan's test involves asking the patient to hold their wrists in a fully flexed position for about 30 to 60 seconds to see if it brings on the numbness or tingling named after George S. Phelan. And another one mentioned in the source is Durkin's compression test.
What's that?
That involves applying direct, firm digital pressure over the carpal tunnel for about 30 seconds. The source notes this test, described by Johnny Durkin, is considered highly sensitive and specific for CTS.
How do you definitively confirm the diagnosis?
While the clinical history and examination findings are often highly suggestive, electrophysiological studies, nerve conduction studies, NCS, and sometimes electromyography, EMG, are usually performed to confirm the diagnosis. These tests measure how fast the electrical signals travel along the median nerve across the wrist. Slowing of the nerve conduction velocity as it passes through the carpal tunnel is the characteristic finding in CTS. However, it's important to remember that these tests can sometimes be normal, especially in milder or intermittent cases, so a normal study doesn't absolutely rule out CTS if the clinical picture is very strong.
What are the treatment options for CTS?
Non-operative treatment is usually tried first, especially for milder symptoms. Wearing wrist splints at night, holding the wrist in a neutral or slightly extended position can be very effective by reducing pressure on the nerve during sleep. Steroid injections directly into the carpal tunnel can also provide significant relief, often temporary but sometimes lasting, by reducing inflammation around the nerve and tendons.
And if those non-surgical options don't work?
If symptoms persist despite conservative measures, or if they are severe, or if there's evidence of the NAR muscle weakness or wasting, then surgery is usually recommended. The surgery is called a carpal tunnel decompression or release.
What does that involve?
It involves surgically dividing or cutting the transverse carpal ligament, which forms the roof of the tunnel. This effectively opens up the tunnel, increasing the space available for the median nerve and relieving the compression. This can be done through a traditional small open incision in the palm, or, increasingly commonly now, using an endoscopic technique with a camera and specialized instruments inserted through one or two very small incisions. Both methods are generally very effective at relieving the nerve compression symptoms.
Okay. Is the ulnar nerve also commonly compressed at the wrist, like it is at the elbow?
It's less common than carpal tunnel syndrome, but yes, the ulnar nerve can also be compressed at the wrist as it passes through a different tunnel called Guillon's Canal, named after Jean Casimir Felix Guillon.
Where is Guillon's Canal?
It's located on the ulnar side of the wrist, near the pisiform bone. Compression of the ulnar nerve here causes tingling and numbness in the little finger and the ulnar half of the ring finger, similar to cubital tunnel syndrome at the elbow. However, it can also cause wasting and weakness of the small intrinsic muscles in the hand, particularly the hypothenar muscles on the pinky side and the interosseae between the fingers.
Is there a way to tell if the compression is at the wrist versus the elbow?
One key distinguishing feature mentioned in the source is that with compression in Guillon's Canal at the wrist, sensation on the back, dorsal aspect of the little finger and ulnar ring finger is usually preserved.
Why is that?
Because the sensory branch of the ulnar nerve that supplies the back of the hand actually branches off before the nerve enters Guillon's Canal. So if that dorsal sensation is spared, it points towards a problem at the wrist rather than higher up at the elbow.
What typically causes compression in Guillon's Canal?
Common causes include things like ganglion cysts arising from the nearby joints or tendons, aneurysms, swellings of the adjacent ulnar artery, or sometimes fractures of the hook of the hamate bone, which forms part of the floor of the canal.
Okay, let's touch on a vascular necrosis, or AVN. That sounds serious bone death due to lack of blood supply. Can that happen in the wrist bones?
Yes, it can. It's a serious condition where the blood supply to a bone or part of a bone is disrupted, leading to the death of the bone tissue. In the wrist, the two carpal bones most commonly affected by idiopathic AVN, meaning AVN without a clear cause like trauma, are the lunate bone and the scaphoid bone.
What are those conditions called?
AVN of the lunate is known as Kienbuck's disease, named after Robert Kienbuck. AVN of the scaphoid is called Prizer's disease, named after George K.F. Prizer.
What symptoms do they cause?
Patients typically present with chronic wrist pain, often localized over the affected bone, and sometimes stiffness or swelling. Diagnosis is usually made with X-rays, which might show increased density, collapse, or fragmentation of the bone, although MRI is more sensitive in the early stages.
What's the natural history? What happens if it's not treated?
The natural history is often progressive collapse of the dead bone, leading to altered wrist mechanics and eventually the development of widespread degenerative arthritis throughout the carpal bones.
How is it treated?
Treatment depends heavily on the stage of the disease when it's diagnosed. Options range from conservative management in very early stages to various surgical procedures aimed at either restoring blood supply, if possible early on, unloading the affected bone, or dealing with the consequences of collapse and arthritis. For end-stage disease with severe arthritis, procedures like partial or complete wrist fusion are often necessary to provide a strong, stable, and painless wrist. The source notes that while fusion obviously eliminates wrist motion, the functional limitation is often not as severe as patients might initially expect.
Okay, let's talk about ganglion cysts. These are probably the most commonly noticed lumps or swellings people get on their hand or wrist.
They are indeed the most frequent soft tissue swellings seen around the hand and wrist. Ganglions are benign, fluid-filled cysts that typically arise from an underlying joint capsule or a tendon sheath.
Where do they usually appear?
The most common locations are the back dorsal aspect of the wrist, often arising from the scapholunate joint. They can also occur on the front volar aspect of the wrist, typically near the radial artery. Another common site is on the back of the finger near the N joint, DIP joint. These are called digital mucus cysts and often occur in patients with underlying OA of that joint. Mucus cysts can sometimes thin the overlying skin, leak clear gelatinous fluid, or cause grooving or deformity of the adjacent fingernail. A fourth common location is arising from the flexor tendon sheath at the base of a finger in the palm. These are often small, firm, pea-sized lumps called seed ganglions.
What symptoms do ganglions cause? Are they painful?
Often, they are asymptomatic apart from the visible lump. Wrist ganglions might cause a dull ache or discomfort, especially with activity. Mucus cysts might cause concern due to leakage or nail changes. Seed ganglions at the base of the finger can be quite tender, especially with gripping activities.
What are the characteristics on examination?
Ganglions are typically smooth, well-defined lumps. They usually feel slightly soft or fluctuant, though they can sometimes feel quite firm. A key diagnostic feature is that they transilluminate, meaning if you shine a bright light through the lump in a darkened room, the light passes through the clear, gelatinous fluid, making the whole cyst glow. Solid tumors don't do this.
How are ganglions treated? Do they need to be removed?
Treatment is often not necessary if the ganglion is asymptomatic and the diagnosis is clear. Reassurance is often sufficient. If the ganglion is causing pain, interfering with function, or is cosmetically bothersome, treatment options include aspiration.
Draining it with a needle.
Yes, draining the thick, jelly-like fluid with a needle. This often provides temporary relief, but recurrence rates after simple aspiration are quite high because the cyst wall and its connection to the underlying joint or sheath are left behind. The other main option is surgical excision of the entire ganglion cyst, including its stalk down to the point where it originates from the joint capsule or tendon sheath.
Is recurrence possible after surgery too?
Yes, recurrence is still possible even after surgical excision, although the rates are generally lower than with aspiration.
Okay. Finally, the source material we're drawing from briefly mentions congenital malformations of the hand and wrist, but points to another chapter for full details. It does provide a classification, though.
Right. It refers to Chapter 44 for the detailed discussion, but includes Table 38.2, which gives a useful classification system based on the underlying developmental error. These categories include defects in formation of parts, meaning parts of the limb might be partially or completely missing. Defects in differentiation or separation of parts.
Like fingers being fused together.
Exactly, that's syndactyly. This category also includes things like fingers being congenitally bent, camptodactyly, or curved sideways, clinodactyly, or the radius and ulna bones being fused together, radioulnar synostosis, or a specific deformity causing the tip of the little finger to curve radially, Kerner's deformity, named after Joseph Kerner. Then there are duplications.
Extra fingers.
Yes, like polydactyly. There's also excess development, like macrodactyly, where a finger or part of the hand is abnormally large. Insufficient development or hypoplasia, where a part is underdeveloped or too small. Constriction band syndrome, thought to be caused by amniotic bands wrapping around parts of the limb in the womb. And finally, congenital hand differences can be part of generalized skeletal anomalies or wider syndromes like Marfan syndrome, Turner syndrome, or Down syndrome.
That truly was a deep dive. covering an immense amount of ground in the orthopedic landscape of the upper limb. From the intricate mechanics and common problems of the shoulder down through the elbow and into the complex world of the hand and wrist. We've touched on issues right from birth defects through to degenerative wear and tear, infections, nerve compressions, and so much more.
It really underscores just how interconnected all these structures are, doesn't it? And also how many different pathological processes, inflammatory, degenerative, traumatic, infectious, neurological, can impact their function. As we've seen repeatedly, diverse conditions can sometimes present with surprisingly similar symptoms, which really emphasizes why that thorough history-taking and detailed physical examination are so absolutely critical to arrive at the correct diagnosis and guide the right treatment.
Absolutely. Navigating through the detailed anatomy, the underlying pathology, the diagnostic approaches, and the various management strategies laid out in our source material today has, I hope, provided a really solid framework for understanding this vital part of the body at a much deeper level. Whether you're listening as a student, a healthcare professional, someone trying to understand a personal health issue, or maybe you're just fueled by sheer curiosity, really grasping these details like the professionals do is incredibly valuable.
It is, and perhaps as we wrap up this extensive exploration, here's something to consider. The upper limb is undeniably a marvel of biomechanical engineering honed by evolution. But it's also clearly vulnerable to acute trauma, yes, but also to the slower, more insidious effects of the passage of time, our individual genetics, underlying systemic diseases, and maybe most significantly, how we use and sometimes overuse our arms, wrists, and hands in modern life.
That's a great point.
So, the question to ponder might be, considering these constant and perhaps increasing demands from our lifestyles, coupled with the fact that we're generally living longer, how will our understanding and our treatment approaches for these foundational orthopedic problems of the upper limb need to continue to evolve and adapt to keep pace with these ongoing and future challenges?
That's a really compelling thought to leave everyone with. Thank you for joining us on this very deep dive.